Herzlich willkommen. Mein Name ist Marc Zickes. Ich bin Vorstandsmitglied vom Forum Managed Care. Jetzt werden wir uns nach Washington zuschalten, um einen Beitrag von zwei Leiter vom NACCOS hören. NACCOS ist die National Association of Accountable Care Organizations in den USA. Wir werden jetzt schauen, ob wir jetzt schon zugeschaltet sind. Heute haben wir mit uns Herr Brian Hammer. Er ist Vice President und zuständig für die Membership and Business Services und Frau Melody Danko-Holsomback. Sie ist Vice President für die Education von der National Association of Accountable Care Organizations. So Brian and Melody, can you hear me?
Yes. Good morning, Mark.
Good morning, Brian. Good morning, Melody. It's 4:05 here in the afternoon, but nevertheless, we're very happy to have you with us today. Thank you very much to be here with us. So you can't see us, but we can see you. We have a nice big room here with about 40 to 45 persons carefully listening to you. So I introduced you shortly, and I will not speak any longer. So the floor is yours.
Well, thank you very much, Mark. We appreciate the warm and welcome here. Again, I'm Brian Hammer, and I'm with the National Association of ACOs, or NACCOS. And you'd be wrong, Mark. We can see all of you. We see the backs of your chairs from the cameras, so we know you're there, and we appreciate the time with you. So just to let you know, we're going to talk a little bit about our experiences and the introduction of implementation of ACOs in the United States. I'll be controlling the board here, so thank you for that warm welcome, and you can see our bios here. So talk to us at any time. You can also visit us at NACCOS.com and find out more information there. So a little bit about NACCOS. NACCOS, that's what we call ourselves. It's just easier to say the National Association of Accountable Care Organizations. It's a mouthful. But what we are at NACCOS is we are the largest membership organization in the United States that's been formed and is currently governed by ACOs. So our whole agenda is working to increase quality outcomes for patients in the value-based care space. We're here to help improve patient experiences and also lower costs and wasteful spending across the healthcare medium. Being the largest organization in the country does have its benefits. We have large congregations. In fact, we have a conference ourselves in a couple of weeks in Baltimore, Maryland. It is the largest congregation of ACOs under one roof. We do it twice a year. And really, it's about just bringing together these ACO professionals, these leaders, the people that are the top minds in the value-based care space, to really bring together best practices to identify issues that may be creating barriers for success for ACOs. And NACCOS acts as that voice nationwide. We represent, all voices of ACO. We represent them to the Centers for Medicare and Medicaid Services. We represent up on Capitol Hill with various lawmakers, as well ultimately with the White House. So a little bit about where our members are. NACCOS represents about 70% of the market share of ACOs in CMS programming. You'll notice all these little fun pins here. These little pins represent headquarters of all of our ACO members. We're in all 50 states, including the District of Columbia. Now, you may see a couple of states that are a little bit blank here. These are some more of these rural pockets, but never fear. It just means that we have somebody in one of these respective headquarter pins servicing beneficiaries in those respective territories. Truth be told, there is one geographic area we are not in, unfortunately, and that's the Caribbean. And I've told the board of directors that they need to send me there in person for a minimum of 2 weeks to secure those relationships. So we have a board meeting next week, so I can't wait to hear their response. So hopefully sunny skies for me. So let's talk a little bit about what an ACO is, right? So an ACO really it's a model-based market solution that relies on local physicians, hospitals, and other providers, and they're really just taking the responsibility for the quality outcomes and the total cost of care for their patient populations. But in order for an ACO to really be successful, it has to work together. And if you see here, you'll see the quintuple aim. Now, initially, back in 2007, the Institute of Healthcare Improvement coined the phrase the triple aim. And the triple aim was really about improving healthcare quality outcomes and improving patient experiences and ultimately trying to reduce wasteful spending. But several years later, we started to realize that clinician well-being is really paramount to this whole operation. In other words, if you don't take care of the people that take care of you, then the whole house of cards is going to fall, and you don't want that. So, you know, physician burnout is definitely something that we've experienced here in America. And you look at the fact that we're now, you know, just coming out, hopefully, of a pandemic, a worldwide pandemic, and it has really stressed our clinician, you know, networks. So putting physicians into that frame of mind and boosting their morale and boosting their mental health and awareness is really paramount to the success of the program. And then several years after that, we also recognized patient equity. Now, what we mean by patient equity is social determinants of healthcare. If you don't understand the fact that 70% of most health outcomes are determined by various social determinants of health, then the chances at trying to transform healthcare is not going to take off. So that's why we look at these 5 different factors. And Melody's going to speak a little bit more about the inner workings of operations. Now, there are various benefits to having an ACO. First off, you think about having an ACO structure will allow for more collective purchasing options, such as care management, analytic support with vendors, et cetera. So you can kind of pull your resources together and negotiate better terms for certain services. We talked about the collaboration of hospitals and provider communities and social services. So, really gets into more of broadening the promotion of preventative care, right? So, if you can stop something before it happens, that will save you money down the road as well and also improve outcomes. We also talk about supporting the community and federal efforts to help transform the care model from fee-for-service to value-based care. And it can also lead to healthcare provider satisfaction. And those are kind of intertwined, because the way we look at it too is, in a fee-for-service world, there's not a high level of satisfaction when you're only seeing a patient for 5 minutes and then you're worrying about, okay, I only have 5 minutes with this person. I can only have this much time to talk to them, find out this. Now I have to send them to various tests. And that could be very wasteful. Wouldn't it make more sense to practice at the top of your license and maybe spend 20 minutes with these patients? And that way you can then determine, okay, I'm going to rule this out, rule that out, and also develop a better relationship with the patient. So overall, better outcomes, better quality for patients, and aligning quality metrics to increase the emphasis on those measures. Now, very briefly, I want to talk about the ACO matriculation of participants in the America program here. So you'll notice that 2012 we started out and we had a nice ascension of interest and participation. And as about 2018 we were at our peak. You'll see that thin red line there that talks about the pathways policy that was enacted by the former Trump administration, where they were more interested in pushing providers and hospitals into risk faster. And as you can well imagine, there are some physician groups that are out there that just weren't ready to take on that level of downside risk. So we started to see a little bit of a lapse or non-renewal, I should say. But what's interesting about this is, even though some of the ACOs dropped off, their participation still remained because they went and joined larger organizations and shared that risk. So the beneficiary lives remained constant. Now, as we all know, we had our pandemic start in 2020. That was, and then 2021 came about, and the program actually hit pause. So there were no new classes of ACOs in 2021. However, there was a new iteration of ACO, which is called direct contracting, which we could talk about at another time. But that was another 53 participants. So a lot of folks had migrated from this program over to there. Now in 2022, we have a new program in place, as well as adding to that new direct contracting, which is now going to become ACO Reach. It's going to be rebranded. It's going to be relaunched in 2023. And you can add another 99 to that. So at this point in time, as a snapshot, we have the highest participation of groups in the ACO landscape. And again, speaking about those beneficiaries, as I mentioned before, you saw, if you can imagine that red line between 2018 and 2019, you saw the lives pretty much stayed the same, so nobody really left. And then as you saw in 2020 with our new class, the numbers started to go back up again, okay? That said, there's a very busy fact sheet here that you can find on cms.com. But here's something that I really want to point to your attention is the party is over here. And as you can see, about 500,000 lives, over 500,000 physicians and non-physician participants are treating patients in accountable care space. So a lot of busy numbers here, but you could see percentages of people that take on one-side risk, two-sided risk, the different composition levels of savings, which I'll talk about at the end of this presentation, but a lot of great information to digest here. And with that, I'm now going to hand things over to my colleague, Melody. Melody, would you like to take it away?
Great, thank you, Brian. So I'm going to take a journey into a little bit more of the operational aspects of an ACO and talk about that ascension into the startup and where you go from there. Year one is really your organizational year where you're getting your data, your claims, you're doing your assessments and creating your plans on how to act on your current state. Year two, you're implementing on those plans, embedding people and workflows into your practices and starting to see the changes for that. Year three is a good year for evaluation because you have your previous years, historical data to look back on. And at this point, you should start to see some positive movement. It may not be where you want to be, but it should be in the positive direction. And it's a year of reflection to see if you want to tweak or change anything. And then year four and beyond is really that continued cycle of evaluation, redesign, adding more innovation and improving your evaluation process. Next slide. ACO structure has a lot to do with provider engagement, and Brian had touched on this, that there are different types of ACOs, and we see kind of two major groups, so your physician-led, smaller, more independent ACOs, and then your hospital or vendor-led ACOs that act as conveners for more employed, and or they can bring in smaller groups as well. But the engagement in each of these groups can be different. The smaller groups are more primary care. They may have specialists in them, but the primary care providers usually outnumber the specialists. And in the bigger institutions where you have hospitals involved, you often see there are more specialists in the ACO than there are primary care providers, even though the primary care providers are the ones who draw the patient attribution into the model. So it's a very interesting pulling together of your providers, and how you engage them can vary depending on this construct of the model. Next slide. So again, when you're looking at those contracts, hospital conveners usually have larger budgets. They can provide that support for the smaller independent providers who may not have additional startup money. It can be costly to start care management services and contracts for analytics and things if you don't already have those in place. So the hospitals and conveners can help support that, and they can be based on risk type contracts as well. So if they don't provide the support that's needed, then everybody kind of wins or loses. Whereas your LLCs or your smaller provider-led companies are usually share in that ownership in both savings and losses, and take that money and share evenly. And there's an example of how shared savings are distributed later that we'll go through. Next slide. So Brian touched on this really for your incentives for collaborating, your value-based purchasing. It's much easier to go into larger contracts for less cost when you have a group versus your smaller volumes. So that is one of the advantages. Unifying your network. If you have an ACO that's managing a contract and it's for multiple practices, you're saving that administrative cost so that you each don't have your own individual costs. It's all rolled up into one. You're sharing it. There's better communication, and it relieves the burden from the providers to actually do that and puts it on its own administrators. Organized and coordinated services include your care management, compliance officers, and quality managers, and they can lead to that increased patient and provider satisfaction. And then, of course, data sharing. Under these contracts, you're allowed some leniency on the data that can be shared outside of your HIPAA requirements in the United States, and can share Excel files with data that's, financial, claims-based, patient-based, using health information exchanges to get reports from hospitals to providers more easily. And then independent dashboards can be built within your EMR systems or your individual systems, and they can lead up even to a population health platform that is sponsored by your ACO. Next slide. So this is one of the compensation models, and there are varied models. People can kind of do what they want with their distribution. In this one, the ACO or the administrative leader is taking 30% off the top to use in that operational and funding for future initiatives. Well, the other 70% is distributed between your primary care, which are your PCPs, receiving 80%, and your specialty care receiving 20%. And the reason of this is the PCPs draw that attribution, and they are really doing the volume of care for these patients. They're the administrators, the gatekeepers, the ones that are managing referrals, trying to keep patients well, and really responsible for the program. Whereas the specialist, you are episode-based, and they're not going to see the patients as much, but they do contribute a majority of the cost. So bringing them into the share helps with that engagement. Next slide. So this slide talks about the governance structure. ACOs have board of members, which are a mix of administrators, and we try to be a little bit heavy on provider administrators to make sure that the regulations, the rules, the plans are really provider focused. We want, the whole idea is to help providers and our care teams to build value-based programs that make sense both to them and their patients. Committees may include your compliance, data and analytics, quality and performance, network and finance, and clinical or medical officer committees. Next slide. And then your ACO startup staff. Of course, you need your chief CEO or your chief officer that's responsible for your execution and oversight of the contract, a medical officer, a operations director for implementation, care management staffing with a strong nurse leader, actuary and data IT staffing for claims, EMR, and other financial various data, quality managers for reporting and implementing strategies for quality improvement, and optional positions that can be helpful are practice transformation staff to work within the practices, patient engagement, and marketing staff. Next slide. So, your keys to success are really to keep an open mind, use your data to find opportunities for improvement, and create real actionable plans that are obtainable around those opportunities. Start with easy wins and build upon them to keep your engagement. And then, develop and implement shared data resources and registries to help support and provide constant feedback to keep that momentum going to achieve your savings and move to value-based care. And with that, Brian, back to you.
All right, so thank you, Melody, that was helpful. So just very briefly, just want to share a nice little comment from Chiquita Brooks, who is the administrator at CMS. And really, it's a demonstration of how accountable care organizations are part of the Affordable Care Act success story. Basically it says that, we set out to improve quality, lower healthcare costs, and the program is demonstrating that. So, with that success, CMS is also, committed to improving upon the model and learning more from the participants. And that's where, folks at NACCOS ourselves, we're very happy to engage with them and, share with them, the triumphs, but also the struggles that are happening in this space. So we want to promote that affordability and sustainability. So the results are in. We have performance year data that is launched every year, and it talks about the quality results as well as the financial savings that the ACO participants are able to demonstrate. That's another reason why we're able to have such interest at our meetings twice a year, because everybody wants to talk about who made money, who almost made money, who owes money back to CMS, but most importantly, why. And that's why we have the conversations we do. But as you can see from this performance year, this latest one, over 500 ACOs participated, and 2/3 of them received shared savings checks back from the programming. And in total, they earned, in terms of performance payments, over $2.2 billion, billion dollars. So this takes time, though. This doesn't happen overnight. So as my next slide will demonstrate here, here's a little snapshot into our journey. All right, so as you can see, the Medicare Shared Savings Program and MSSP, the Next Generation ACO, as well as the Pioneer ACOs, demonstrated, these gross versus net savings. So you can kind of take a look, and ACOs are not unlike a startup company. You have to put, some investment money, some upstart capital into your programming. Understand that there's going to be some losses, in the early going, for the majority of the time. There's only a handful of people I've seen that have been able to strike lightning, where year one they see savings immediately, and that's fantastic for them. But it's a smaller percentage of folks that see that. It's usually year 2, year 3, people start to hit their stride, and that's very evident here in the savings. And as you'll notice, by the time we got to 2020, we're saving the trust fund over $2 billion, the American Trust Fund for Centers for Medicaid and Medicare Services. So it's a great story, and we're very excited for that. So with that, I think we're just about out of time. I have my timer going here, so I hit it when Mark was going. So I think we've got some time for questions. We're happy to take them. If we don't get to your question, we're happy to just receive email from you. We can talk offline at info@naccos.com. So with that, I'll pause here for station identification and comments or questions.
Well, thank you very much, Brian and Melody. So we'll take a couple of questions from the hall here. Sie können Fragen stellen auf Englisch oder auf Deutsch. Wenn es auf Deutsch ist, werde ich eine Übersetzung machen. Gibt es eine Frage? Well, yes, we have a question.
Melody, thank you for your presentation. It was really interesting. One question: when I'm a patient, how I become a member of an ACO or part of an ACO during my doctor or during over my health plan? So, what's the way for a patient to get a part of an ACO?
That is a great question. There are a couple of ways that people can become members of ACOs. So for the Medicare ACO, they have what they call a plurality of care attribution. So if you see a provider, if you have Medicare fee-for-service and you see a primary care provider more than other primary care providers, that's how you get attributed to that provider. So if you see your normal doctor twice a year and for a visit, and maybe you see a specialist in another facility, but the primary care codes and their designation are what can bring you into that attribution. There's also a way that patients can go into Medicare.gov and self-assign themselves to their doctor, so that automatically in that next year, they will be assigned to that doctor's ACO. So right now, those are the 2 ways that you can join.
Thank you very much. Eine weitere Frage. So maybe I would have a question for you. You briefly talked about the KPIs which are being used to measure performance. Do you have standardized KPIs across the whole organization, of across all ACOs in the USA, or does every ACO have its own freedom to set up its own set of indicators?
Yeah, so for your contracts with Medicare under the Medicare Shared Savings Program, they have one set of rules. And then as Brian talked about, the REACH program or direct contracting has another, but each one have their own benchmarks for cost. They have a range of quality metrics that can include things like your flu shots and colonoscopies and breast cancer screenings, along with claims information and claims benchmarks for hospitalizations rates, emergency room rates, chronic, acute care, chronic condition rates, and so forth. And they are all bundled together then in a comprehensive score. But along the programs, each program has their own defined measures. And there's also patient satisfaction scores with each of those that are included.
And I can add to that as well. We also have, outside of the governmental, public ACO contracts, we have commercial contracts, which are private and individualized to those specific negotiations with a payer and, say, a practice or a hospital. They have their own, key indicators that they put together and they agree upon.
Right. And if I may add, one of the missions that we're working on and advocating for is alignment of all those programs to reduce provider burden. So it can be very strenuous on your staffing and your providers to understand who wants what and how they want it. So that's one of our missions that we haven't totally completed yet, but we're on the way.
That's very exciting. Thank you very much. If there is no further question, I would like to add one question. How do you bring providers, primary care doctors, for instance, to onboard and to go into an ACO when you have a new ACO which is being founded somewhere? Because it can be quite of an issue to bring people into a new boat like this with new rules, and they are very, from my perspective and my experience, you can see that they are very wary of losing some of their income if they get into a scheme whereby they will be paid by their performance.
Right, and I think that you can start with a contract that is, you're not supplementing their whole payment. So there are some that you can supplement portions of their payment rather than their whole payment based on this quality of care, and then increase your risk over time. And that's the way most of the contracts work. They start with no downside risk to the providers and then advance to more and more risk over the years, which was that Pathways of Success plan that Brian talked about. So that's one method. And there are also, if you have larger hospitals or institutions, sometimes they will sponsor smaller practices that don't have the capital to go into that risk until they get the processes in place and have them steered in the right direction. They're showing some positive returns, and then allow for those contracts, to ramp up and take on more risk. So there are several ways of doing that.
And I like to add to that too. So before my time at NACCOS, I worked for a nonprofit health system. And the reason why I'm here today was because I had to build recruitment for physician participation within our ACO. And really our goal was to get these providers to just understand that there's got to be a little bit of a change in perception. We understand that there's a monetary component to that, and to Melody's credit, yes, sometimes the hospitals will help subsidize a smaller practice, or maybe it'll happen in chunks or phases. So we weren't glib to that, but I think it also requires to have strong leaders kind of at the top to help influence the providers to come on board. And I know, working with, our chief medical officer and our VPs for medical affairs, as an example, they acted as champions to, really, bring on, these providers, and it just made the conversation a little bit easier. The fact that we started out at a no downside risk arrangement, the way that it was initially pitched was, hey, you've got nothing to lose. But what we see right now, if you continue the status quo, you're going to see incredible wasteful spending. You're going to see burnout. And the providers actually, now that we fast forward to, almost now 9 years later, physician satisfaction scores have been increasing across that medical team and that hospital administration. So just a couple of other items to include there in terms of color commentary.
Great, thank you very much. I think we have a question from the hall. Bitte können Sie sich vorstellen, kurz.
Yeah, thank you for the presentation. I'm Daniel Dröschel from Optimedis AG in Hamburg. In addition to the question before, because it was also my question, I would be curious to understand what is your experience, how much easier is it to attract young professionals? And I'm also not addressing physicians, but all the other healthcare professionals.
Mel, you want me to take this one?
Sure.
Yeah, I'll take this one. So I wore another hat when I was at that health system. I was also into physician recruiting. I was the guy that, quote unquote, bought your practice, walked in, did all the due diligence, closed the deal. But I also had to work with young physicians. And it's really just interesting when you start to realize that now you're becoming older than the doctors that are coming out of medical school. So it was a really eye-opening thing for me in terms of my, growth, understanding that now I'm an adult. But what I came to find with a lot of these new physicians was they were valuing, instead of the almighty dollar, they were valuing more balance. They were looking for more, time to spend with their families. And it was really just an interesting paradigm, because when you talk to the old school physicians, the doctors that, would be up for, 24, 48-hour shifts, working, as a hospitalist or, working in their residencies, and now they're seeing the new guard come in and say, we value money, yes, but we also value our time, and we want to be able to have families. We want to be able to go and enjoy ourselves, because we have been, quote unquote, killing ourselves in medical school and getting up to this point. We want to have at least a little bit of fun. So when you describe something like value-based care to a younger audience, it does kind of feed it more into that mode or that mentality of, hey, I can spend more time with my patients. I don't have to, see, a patient every 5 minutes and keep churning and running like a hamster on a wheel. I can spend 15, 20, 25 minutes with a patient, have, a nice relaxed conversation, build a relationship with my patient base so that they will continue to come back and they will respect me and I respect them as patients. And, that turned to be a little bit more of a game changer, especially for our recruitment efforts. So the younger crowd is easier to convince versus the old school one that's been so used and so hard and in battle trained to just say, all right, do this, people, admissions, heads in beds, that's what's going to get me paid. So hopefully that answers your question. Melody, feel free to chime in if there's anything that I may have missed there.
No, you did a great job.
Thank you.
So, Brian, Melody, thank you very much. We could go on for some more hours like this, because it's really a fascinating topic, but unfortunately we have to stop now due to our schedule. Thank you very much for joining us today here in Bern. And we send you a nice hello to Washington, and hope that we can catch up sometime later. Thank you very much, and goodbye.
Thank you very much. Take care.